morning, everyone. We'll get started as people continue to trickle in. It is my great pleasure to introduce you today to a very special guest for our Global Neuroscience Institute Grand Rounds. We have with us Dr. Craig Horbinski. I've come to know Dr. Horbinski during my time at Northwestern during my residency. And I've had the privilege to sit down and listen to some of his lectures and grand rounds, and I can tell you from experience you're in for a treat this morning. Dr. Horbinski is a board-certified neuropathologist and a full-tenured professor at Northwestern University. He directs the neuropathology division of the Department of Pathology, the Northwestern Nervous System Tumor Bank, and the pathology core facility of the Lurie Comprehensive Cancer Center. To date, he has authored over 250 peer-reviewed publications and has obtained extramural research support as a principal investigator from multiple sources, including the NIH. His work has been cited over 21,000 times with an H index of 80. If you guys know, these are tremendous numbers. He has presented over 110 invited lectures at domestic as well as international meetings. He is also an associate editor for the Neuro-Oncology and Neuro-Oncology Advances, and is on the editorial board of Acta Neuropathologica and Brain Pathology. In 2024, he was inducted into the American Society for Clinical Investigation, and he is the current chair of the Scientific Advisory Council for the American Brain Tumor Association. So again, everyone, this is going to be a fantastic talk. Please write all your questions and comments in the chat, and we'll get to them at the end. Dr. Horbinski, thank you for joining us this morning, and we look forward to your talk.
Well, thank you very much, Rudy. It's a pleasure to be here. I hope I live up to that lovely introduction. But thank you for letting me know about my H index finally hitting the big 80. I did not realize that had happened. All right, so today I'm going to be talking to everybody here about molecular diagnostics in brain tumors. All right, so no relevant relationship, financial relationships to disclose. As I was saying, the times they are changing, according to legendary Bob Dylan, and that is most certainly true for microscopy and pathology in general. In 1590, Zacharias Janssen invented the compound microscope, and that's the actual microscope that he created. I have no idea how he saw anything through that thing, but technically that was a compound microscope. And it wasn't until then, 1660, when Anton von Leeuwenhoek invented his own compound microscope, and this one was very interesting. It doesn't look at all like a microscope. It looks like a paddle of some sort, but he was actually able to see with decent resolution up to 200 times magnification. But that was in 1660, and then shortly thereafter, Robert Hooke coined the term cell. When he was looking at plant material under the microscope, he saw these little spaces that reminded him of prison cells. So that's where we get the term cell from. It was a derivation of prison cells. And so that was in about 1665, and nothing happened for almost 200 years, really, until Alexander Butlerov discovered formalin. The reason for this, and by the way, during this time, there was a lot of tremendous advances made in astronomy, but not microscopy. And as it turns out, even though astronomy, is challenging in its own right, it's actually easier technically than microscopy, because whereas astronomy, you need a long tube with a lot of lenses, nicely ground, and you're looking for really big objects in the sky that are more or less self-illuminating. But in microscopy, you're trying to look at super small things, and they're not going to be self-illuminating. They need to be sectioned very thinly for light to pass through. And you need special dyes to see anything, otherwise it's just going to be transparent. And fixatives too, like formalin. So it really took the Industrial Revolution to create the critical mass of materials and reagents and equipment that make true microscopy, as we currently understand it, feasible. And it started in 1859 when Alexander Butlerov discovered formalin. And then in 1861, it was Louis Pasteur who described microorganisms and thought that, yeah, maybe this has something to do, these little bugs have something to do with some of the diseases that we see. Shortly thereafter, William Hiss invented the microtome. And I thought when I found that out, that's the microtome, that's the machine, the very finely calibrated machine that slices tissue sections up to like just a few millionths of a meter thick. So when I found out it was Hiss who invented the microtome, I thought, oh, cool, that must be where we got histology from. Well, actually, turns out to just be a really freaky coincidence, because histology is based on an ancient Greek word named histos. And histos originally meant the tissues that weave us together, that hold us together, or things that hold us together, I should say, on a loom, like, for example, fabrics that are weaved together from fibers. And so that became the tissues that hold us together, and that became histology. At the same time, Rudolf Virchow coined the term glioma. He's considered the father of modern pathology. 1871, Heinrich Caro invented eosin. That's an artificial brominated dye that stains things pink. A little while after that, Paul Ehrlich created a modern formulation for hematoxylin. Hematoxylin is a dye from the logwood tree bark. It's also the same thing that stains your blue jeans blue, by the way. 1892, formalin-fixed paraffin embedding is invented. That paraffin, of course, is just a petroleum byproduct. It's a waxy byproduct. Paul Mayer, later on in about 1895, 1896, combined hematoxylin with eosin together to form this perfect stain counter stain. So nuclei are stained purple with hematoxylin, and eosin stains proteins, etc., pink. And various shades of purple and pink still to this day provide the foundation for histology, for pathology. So just think about that. This was invented in 1895, and here it is 2025, and we're still using it. So just think of something that you invent today that still holds true and is the standard practice over 100 years later. That's pretty good staying power. In 1925, that's when Harvey Bailey and Percival from Johns Hopkins and Percival Cushing from the University of Chicago, they collaborated together to publish their brain tumor classification scheme. And back then, by the way, neurosurgeons like Harvey Bailey were Harvey Cushing and Percival Bailey. Morning brain. Haven't had enough caffeine yet. But Harvey Cushing was back then, neurosurgeons also did all their own pathology, pretty much in the operating room. And that's when you started coming up with terms like ependymoma, astroblastoma, medulloblastoma, things. There are a lot of the terms that we still use to this day. And then we got 1949. That's when James Watson Kernahan at the Mayo Clinic divided gliomas into 4 grades for the first time based on appearance. A year later, Niels Ringertz published his study that said necrosis and or microvascular proliferation could really differentiate grade 4 tumors from grade 3 tumors. Now, you'll see, if I'm jumping back and forth here, you'll see I covered a huge amount of a century's worth of material in just this one time frame. I tried to cram all the molecular stuff at the back end on the right side, but there was too much. There was too much that covered just a few decades. So I ended up having to expand the right side of the timeline, as you can see. You could argue that the molecular era really started in brain tumors way back in 1965, when brain tumors were karyotyped for the first time, as in this case, this is an ependymoma. Alternatively, you could argue that brain tumor molecular diagnostics started in 1973 when this little guy was born. And it was neat because when I was putting this together, I thought it'd be fun to throw in a little baby picture. I mean, how many times you see a baby picture of the speaker in one of these talks? And I asked my mom, because I didn't have any baby pictures of me. I said, hey, could you send me a baby picture, something I could use for this talk? Within 10 minutes, she gave me 6 options by email. So she was prepared. So that was 1973. And then in 1977, Sanger sequencing was invented. And that, of course, was the mainstay, the gold standard for a very, very long time. In 1979, the first mutation was discovered in a glioma. Now, a lot of people might assume it was P53 or something like that. It was actually EGFR. An EGFR mutation was discovered in a glioblastoma in 1979. Fluorescence in situ hybridization was invented by Pardue and Gall back in 1981. And that, of course, was the mainstay for molecular testing for gliomas for a very, very long time, specifically concerning EGFR amplification and 1p19q co-deletion. But it really was actually until 1985 that EGFR amplification was first described in a very small subset of glioblastomas, just 10 GBMs. 4 of them had EGFR amplification. It was kind of interesting, actually, as it turns out, because that's a small cohort, 10 GBMs. And yet that 4 in 10, that 40% ratio, still holds true to this day. With the huge studies, it still is about 40% of GBMs are going to have an EGFR amplification. A year later, gain of 7 and loss of chromosome 10 were described in glioblastomas as being characteristic specifically of GBMs. So that's, of course, by karyotype. And then in 1988, so the St. Anne Mayo system came out that really started to resemble the modern grading approach that we currently use. In 1990, that was the first time that MGMT was described as being methylated in some gliomas. Now, keep that date in mind. That was 1990 when that was first described, that was first published. Because in 1991, then, P53 was discovered to be mutated in astrocytomas. In 94, 1P19Q was found to be co-deleted in oligodendrogliomas. In the year 2000, chromosomal microarrays first came out as a technology. 2001, big year. The human genome was sequenced. That was a seminal event, of course, in world history. But another big year was 2005, because that was the year next generation sequencing was invented as a better way, a faster way of doing a massive sequencing in parallel, much cheaper and less laborious than Sanger sequencing. So think about that. The original human genome was sequenced just with Sanger sequencing. It took, of course, many laboratories across the entire world to do it, and it actually cost over $300 million in today's dollars to sequence one genome. Now, next-gen sequencing can do it for about $1,000, and it's more accurate. That same year, MGMT emerged as a predictive biomarker in gliomas, specifically those glioblastomas that would benefit from temozolomide. So remember, 1990 is when MGMT was first discovered to be methylated in these tumors. It wasn't until 15 years later that it emerged as a gold standard predictive biomarker. So keep that in mind, that 15 years, that's a long time. It takes a long time for these basic laboratory discoveries to mature into clinically tractable assays and improve patient care. 2007 was the first World Health Organization book that at least included molecular features in some of the diagnoses. Now, it's important to mention that yes, the molecular features were mentioned in the diagnoses, but they were not required yet to make a particular diagnosis. And the reason for that, the World Health Organization has always been kind of a laggard in that regard, but by design, because its mandate was to have a system, a classification system in place that could be used worldwide with just a microscope and a well-trained pathologist. So there was a lot of these molecular testing that everybody knew was important and was useful, but they didn't want to make it mandated, because if you bake it into the diagnostic criteria, then it becomes mandatory, and that could be a problem for a lot of places throughout the world. In 2008, the Cancer Genome Atlas published their first study, and as luck would have it, they focused on glioblastomas at first to really get throw a lot of spaghetti against the wall, multidimensional spaghetti against the wall, genomics, epigenomics, sequencing, of course, copy number, and just really dive in deeply to what are the major core pathways that are altered in these tumors. That same year, the 450K methylation array was released, because the original methylation array about 8 years prior was 27,000 probes on the array. Not a big coverage, because keep in mind the methylome, the CpG sites in a human genome, about 28 million. It's about 28 million CpG sites that could be methylated. So the 27,000 array was covering just a tiny portion of that. 450K was still a tiny portion of the total methylome, but it was a big improvement. IDH mutations were discovered in gliomas for the first time. This is back in 2008. BRAF fusions were discovered in pilocytic astrocytomas in 2008. So 2008 was also a big year. In 2011, that was the first time that somebody had published results on medullos saying, you know what, these tumors, there's actually four major subtypes, four subgroups of medulloblastomas with fairly different clinical outcomes. Since then, it's been further refined. And now, for example, there's 8 methylation subtypes, 3 of which are especially bad. So the field is constantly evolving. Nothing is set in stone. In 2012, histone mutations were discovered for the first time in pediatric high-grade gliomas, starting with the midline and then, of course, the lateral hemispheric tumors. Then and in the old days, this is even when I was just a trainee, we thought there was like 3, maybe 4 subgroups of ependymomas just based on morphology. When all of a sudden, by multidimensional molecular, like, oh, hi, actually, there's actually 9 subgroups of ependymomas that you need to know and be aware of because they do differ by location and clinical behavior. In 2016, this was now the first book that actually had molecular diagnostics baked into the criteria, because by that point it was just so overwhelming. And there was no way you could recapitulate all of that by just histology. In 2017, that's when methylation patterns in meningiomas emerged as potentially prognostic. In 2018, that's when the big study, the big Nature paper from the Heidelberg group, it was actually an international paper, showing that you could classify central nervous system tumors based solely on DNA methylation profiling, the patterns of methylation, based on that 450K array I mentioned earlier. And then here in 2021, was the 5th edition of the WHO book. That's the most recent one, of course, that came out. And that's a monster loaf because it now contains all kinds of molecular data and molecular criteria. In 2022, we learned that copy number alterations are probably more important for meningioma prognosis than specific mutations. And finally, here in 2023 was the first report, clinical trial, randomized clinical trial, that IDH mutations could be successfully targeted in grade 2 astrocytomas and oligodendrogliomas. And remember that the original discovery was back in 2008. So you're looking at once again, another 15 years between the original discovery, original wet lab discovery, and a clinically tractable intervention to improve patient care. So 15 years seems to be a common pattern for major central discoveries to be translated into patient care. Just to illustrate how complex this stuff has gotten, I got a hold of old World Health Organization books, and I have everything from the year 2000 onwards. But I didn't have, it actually started in 1979. I couldn't get a hold of that book, real small, thin book. But I had the 93 and 97 books lent to me by somebody else. And I lined them up side by side, as you can see, just to illustrate how complicated this stuff has gotten, how fat the books are getting. And this is being driven entirely by molecular testing. And this is, for example, this is just a list of some of the newer tumor types that are new categories that we have now in this 5th edition, this 2021 WHO book. Oh, and I should mention, by the way, just parenthetically, you might be looking, okay, how can this be the 5th edition? There's 6 books here. There's actually a 7th book that wasn't photographed. A couple of the editions weren't considered official editions. They were just like revisions of a prior edition. I don't know how they came up with that. But anyway, the 5th edition is 2021. But you can just look at the table of all the new tumor types and subtypes, and how in most cases you've got specific molecular alterations now baked into the diagnosis. They're defined as, for example, glioblastoma, IDH wild type, astrocytoma, IDH mutant, so on and so forth, astroblastoma, MN1 altered, so on and so forth. And so molecular testing is necessary to really be in compliance with the 2021 guidelines. Among the newly recognized tumor types, the entities that previously were not even really mentioned in the WHO book except as possible subtypes, these new entities, most of them have specific molecular alterations baked into the main diagnostic line. I mean, that's we have to define them. That's part of their terms. And this illustrates how powerful the molecular testing can really be and why it's emerged so prominently in recent years. In the old days, we would call grade 2 and 3 astrocytomas and oligodendrogliomas, and then we thought there was a hybrid oligoastrocytoma, that sort of looked like an oligo, but sort of looked like an astro. This is all before molecular testing. And if you follow all these patients over time, you get this mess of crisscrossing Kaplan-Meier curves. And that underscores how difficult it was to really prognosticate based solely on histopathology the outcomes, especially for these lower grade 2 and 3 tumors. Not to mention the fact that the term oligoastrocytoma itself is kind of, well, I mean, it fell out of favor, obviously, for a reason, because for one thing, the inter-observer variability was extremely high. 10 neuropathologists could look at the same tumor, and a handful will call it oligoastro, and the others will call it something else. So it was very confusing for everybody. The exact same cohort here, this exact same cohort of tumors can be stratified by two simple markers, IDH mutation and 1p19q co-deletion. And if you do it by that, you can see the curves sort themselves out much cleaner than they did before. So that really, I think, nicely illustrates how, even though in many cases molecular testing can seem like it makes things more complicated, I would contend that in most cases it makes things more simple because it's adding an objective layer of metrics to what was previously a very subjective practice. And just FYI, for some reviews on the subject that pursuant to the WHO classification, I published one in Nature Reviews Neurology a couple of years ago. And more recently here, this has just come out in JAMA Oncology. What we're really trying to do is advocate. This is more of like a consensus statement, a white paper, trying to advocate for full molecular testing for all these central nervous system tumors so that insurers and third-party payers would not balk at covering this stuff because it really does provide incredible amounts of information. And if you don't test every case, then you don't know what you're missing. And many surprises can be found in molecular testing that really do impact patient care. And to illustrate this, we're going to go through just a handful of cases here because the field is so complicated to try and delve through all the different categories. It gets bewildering and people's eyes get bleary and all that. So instead, a case-based approach seems to be more effective. So that's what we're going to do. These are real cases that I encountered during my practice over the years that demonstrate the power of the molecular testing. So here we got a 46-year-old woman who has a left frontal mass, as you can see right here, and it's resected, of course. And under the microscope, we saw infiltrating tumor cells. We see some blood vessels here, obviously, but it really didn't quite, to me, make the cutoff for microvascular proliferation. It was just some prominent blood vessels. But there was a microthrombus within one of them, and there was mitoses elsewhere. So there's no question about it being a high-grade glioma. But is this a GBM or is this something else? Well, as it turns out, it was immunonegative for the canonical IDH1R132H mutation and also negative by sequencing. So it was IDH wild type. And next-gen and Oncoscan results. Oncoscan's our genomic copy number profiler. We were able to determine that, yes, indeed, it was wild type for even the non-canonical variants of IDH1 and IDH2. It had a TERP promoter mutation, it had EGFR amplification, and gain of 7 and loss of 10. So this speaks to the adult type diffuse gliomas. This might be the highest yield slide I have in the entire talk. We've got three flavors, as many of you may know. There's astrocytomas, oligodendrogliomas, both of which are IDH mutated. And then there's glioblastomas. And in most of our practice, I'd say the majority of our neurosurgical practice, at least pertaining gliomas, is involved in resolving these three tumors apart from each other. And there are certain very highly stereotyped mutations and copy number alterations that are associated with one, but not the others. And so as a result, we can reliably classify these tumors, even sight unseen. I can tell you whether something is an IDH mutant astro or oligo or GBM just by looking at the molecular profile without even necessarily looking at the slides. Here's another one that might be useful for you. It's also in the Nature Reviews Neurology, a manuscript that I published a few years ago. It's a basic flow chart where you start off with a diffusely infiltrative glioma histologically, right? And the first node is to determine whether or not it's IDH mutated. And if it's not, then you have to determine whether or not that thing has necrosis and or microvascular proliferation under the microscope. And if it does, then you can call it an IDH wild-type GBM grade 4. If it does not, then you got to look at TERT, EGFR, and gain of 7, loss of 10. If those are present, then even though you don't have necrosis and MVP, you can still call it a GBM. If it has none of the above, then it's really a good idea to further evaluate this tumor because it may be something else entirely. On the other hand, if the tumor is IDH mutated, all right, now you know it's a race between astrocytoma and oligodendroglioma. And if it's 1p19q co-deleted, it's an oligo. And then from that point on, you're looking for markers of higher grade histology, mitosis, necrosis, etc. And you're splitting it between grades 2 and 3. Which really does matter. Grade 2 versus 3 does matter prognostically for oligodendrogliomas. On the other hand, if it's 1p19q intact, you look histologically, okay, now you know you're dealing with astrocytoma because it's IDH mutated, but it's 1p19q intact. Does it have necrosis or MVP or homozygous CDKN2AB deletions? That's a cell cycle checkpoint protein, codes P16. So if that is present, if either one of those two things are present, you can call it an IDH mutant astro grade 4. If it has elevated, if it's none of the above, but it has elevated mitoses, then you can call it a grade 3. Otherwise, it's grade 2. And here's where things get a little fuzzy because it's not at all clear. Unlike oligos, it's not at all clear that there's really that much difference in outcomes between grade 2 and 3 tumors for astros. And the mitotic activity, nobody's been able to settle on a cutoff, a specific cutoff for mitotic activity, whereas in oligos, the general cutoff is 6 in mitoses per 10 high power fields. Nobody's been able to come up with a similar cutoff for astrocytomas. So it's a little fuzzy as to this grade 2 versus 3 business, whether that's even a real thing or not. But in this particular case, this current case, it clearly lines up with IDH wild-type GBM grade 4. Following that flow chart, of course. So in case 2, we got a 29-year-old man, in contrast, who's got an enhancing mass in his left frontal lobe that was resected. Under the microscope, there's a lot of necrosis. That's at low power. There was a lot of necrosis up top, lots of microvascular proliferation down below. Here's the necrosis, and there's a microvascular proliferation. Plenty of mitoses, of course, as well. So it's already got grade 4 histology, or high-grade histology at any rate. And no microthrombi or anything else as notable features, but this thing really was positive, strongly immunopositive for the canonical IDH1R132H, which you would expect in a 29-year-old. It's going to be a lot more common than in an older person. And by next-gen sequencing, the IDH mutation was confirmed, as well as mutations in ATRX and P53, and really piling on homozygous CDKN2AB deletion. So back to that flow chart, this thing has it all. It's got all the hallmarks of a grade 4 astrocytoma. It's intact for 1p19q. It's got ATRX P53 hits on top of the IDH. It's homozygous for CDKN2AB deletion. And there is actually some emerging data that suggests, for whatever it's worth, in recent years, that even if an IDH mutant astro has necrosis and or microvascular proliferation, yeah, technically, according to the 5th edition, it still is grade 4, but it may not, but the grade 4 IDH mutant astros tend to still behave better, relatively speaking, than your IDH wild-type GBMs, okay? Unless that same tumor also has homozygous CDKN2AB deletion. Because even within the grade 4 world of astros, that deletion really squeezes it even closer to being an IDH wild-type GBM, at least as concerns outcome. So even if you have necrosis and an MVP, there may still be benefit in screening these suckers for CDKN2A deletion. Anyway, I should mention, and so according to the older way, we would call this an IDH mutant glioblastoma, WHO grade 4, but now That term GBM is now refers exclusively to just IDH wild type, adult type diffuse gliomas that have, histopathology and or some of those other molecular features. So in other words, you shouldn't be calling anything that's IDH mutated a glioblastoma. It's ipso facto either an astro or an oligo. Now here's a very different case. This is a third. This case 3 here is an unfortunate man who had no prior medical history, by the way, who presented with this hideous left brain mass and mass effect. Some parts of the tumor under the microscope looked like a conventional really high-grade glioma. But then there was other parts, even in the same slide, that looked very, very different. Morphologically, you can see the differences here, right? You got what looks like a glioma, and here it looks a lot more epithelioid. There's a lot of apoptotic debris. There's more necrosis. The mitotic index is even higher. Big nucleoli. That's those big reddish spots within the nuclei, big nucleoli. And what made things even more complicated was in those higher grade areas, they were negative for our glial marker GFAP, just some background non-specific staining, but instead we're strongly positive for CAM5.2. That's a cytokeratin marker that is typically, it doesn't label gliomas, but it will label metastatic cancer. Super strong, nearly 100% for Ki67, and it clearly had a strong accumulation of p53, which suggests some sort of mutation in p53 that may have rendered the protein inactive or dysfunctional, defective. So the bad protein just accumulates in the tumor nuclei. Those epithelioid regions that were CAM5.2 positive were also positive for stampophysin. So now we're wondering, all right, does this guy have a history of like some sort of neuroendocrine carcinoma that's metastasizing to the brain? Is that what's going on here? In this case, next-gen sequencing showed that it had, as expected, a p53 mutation. It also had amplification of the powerful oncogene called MET, as well as CDK6, which is a major progressor through the cell cycle. That's a cyclin-dependent kinase. Now that's interesting. You see a mutation pattern like that, you're dealing with a high-grade cancer, but it says nothing about where the cancer is coming from. It doesn't tell you anything about the identity of the cancer other than it must be really high-grade. So that's when we turned. This was a few years ago now. Almost, gosh, it's got to be about 8 years ago now. We turned to methylation fingerprinting. And as I indicated before, there's millions and millions of sites, CpG sites throughout a cell's genome that can either be methylated or not. It's a binary thing. At each locus, it's either a 1 or a 0. And that pattern of 1s and 0s across the entire epigenome can reveal the identity of a cell. Is it a skin cell? Is it a lung cell? Is it a bowel cell, etc.? And it can also reveal the identity of tumors that arise from these various different tissues. So as a result, it's proven to be a very, very powerful tool for us to resolve difficult diagnoses, where even microscopy and next-gen sequencing can't help. And this is just a cartoon just to really illustrate. So if you're dealing with a given stretch of DNA and all the little CpG sites are scattered throughout, they're going to be the same more or less from tumor to tumor. Some sites are going to be methylated in all the tumors, like in every given tumor. Some sites, for whatever reason, are methylated constantly. Well, those are not informative, right? They're not going to help you tell one tumor apart from another. Likewise, there are some CpG sites that, for whatever reason, are never methylated. They will also not tell you one tumor from another. So it's the sites that are differentially methylated between and among different kinds of tumors. Those are the ones that really help us. And at any given locus, if all you know is just methylation status at one site, that's not going to help you. You need to know the methylation status at tens or hundreds of thousands of sites for a pattern to emerge that allows tumors to be discriminated from each other. And this, of course, as I indicated earlier in that timeline, was published in 2018 in this seminal paper in Nature. And they got there by developing a classifier from 2,800 CNS tumors. And now we're into the tens of thousands of tumors that have been done over the years. But at the time, they needed about 2,800 CNS tumors to really build the first version of the library. and they were only using the 450K methylation array at the time. And they use something called a random forest algorithm where you combine many weak classifiers, which is each of the individual CPG sites counts as a classifier unto itself. None of them are very powerful on their own, but if you add them all up, you pack a big punch. And this is the sort of outcome you're going to get. So you're going to get a classifier score, which is a numerical score. And the general rule is if you get a score at greater than or equal to 0.9, a perfect match is 1.0. But if you get a 0.9 or higher, that's considered a match. Although there are times when even a match in like the mid eights, like 0.85 or so, is probably good enough. But that's one dimension of data. The other dimension of data we get is something that's really neat called T-dimensional stochastic neighbor embedding, or TISNE. And if you think of each CPG site, each probe on that array is a single dimension of data. What it's doing is this TISNE cluster, and what it's doing is it's compressing thousands and thousands, well, really hundreds of thousands of dimensions of data into a two-dimensional grid that us simple bipedal primates can look at and see differences and see how these different tumors segregate from each other. So for example, in this colored plot, you see all these different clusters. You've got IDH mutant astrocytomas and oligodendrogliomas are out here on the left. That's all the gold colored stuff. Up here in these light and darker blue clusters, as well as this light and darker blue clusters, those four clusters are the four original medulloblastoma subtypes. All these different red clusters you see scattered around here, those are all the different epigenomic subtypes of ependymoma. The purple clusters towards the center, all these various and sundry purple clusters, these are what we now call circumscribed astrocytic gliomas, generally MAP kinase driven. So you're looking at pilocytic astrocytomas, pleomorphic xanthoastrocytomas, and other things like glioneuronal tumors, gangliogliomas, etc. The brown cluster is meningiomas. And this last cluster I'm saving for the very, very end here, glioblastomas, IDH wild-type glioblastomas. So these are the IDH wild-type glioblastomas right here. And then these guys hanging out here are the histone-driven high-grade gliomas. So the G34V hemispheric gliomas, as well as the K27M gliomas. And as it turns out, then, there are 6 discrete methylation subtypes of IDH wild-type GBM. This particular tumor landed in one of those subtypes. So we thought it was going to be a metastatic tumor, but it ended up matching as a GBM. And that prompted a quick literature search, which found that, yes, actually, this little phenomenon of CAM5.2 expression, aberrant CAM5.2 expression in these gliomas, these GBMs, is rare, but it is known to happen. We call it epithelial or pseudoepithelial differentiation. And otherwise, all the features of those common features of those exceptionally, they're almost like grade 5 glioblastomas, if there was such a thing, because they're super mean, super aggressive. And everything according in this tumor lined up with those features. If it hadn't been for methylation profiling, we wouldn't have known for sure that it was actually, yes, it did arise in the brain. It was a glioblastoma, and it was not a metastatic tumor. So in this case, we were able to reliably diagnose him with a GBM, and based on that information, the patient's family would opted for hospice, and he died several weeks later. So you would argue that's not a great outcome, but on the other hand, we gave a definitive diagnosis that let everybody know exactly what they were dealing with, and based on that, they were able to make a very informed, wise choice. So I would argue that methylation profiling worked. All right. Case 4, 67-year-old woman who had right frontal parietal mass. We didn't have the radiology on this thing. In this case, there's no question this sucker's got to be a metastatic carcinoma, specifically adenocarcinoma, because they had all these neoplastic glands with the big nucleoli and all that. It has to be an adenocarcinoma. The question is, where is it coming from? She didn't have any prior medical history of any cancers elsewhere in the body. It was positive for cytokeratin 7, mostly negative for cytokeratin 20, but there were some positive cells. And based on this, we were thinking, okay, maybe it's lung cancer. But it was negative for TTF1, which is one of our lung markers, and it was positive for CDX2, which is a gastrointestinal marker. And this happens more often than you might think, where these immunohistochemical panels that we do on these tumors, especially when it's metastasis from an unknown origin, they can be very confusing because none of these markers are 100% sensitive or specific for any given tumor type. And we have to combine all of them together and make a judgment on where this thing's most likely coming from. It's also worth keeping in mind that these immunostains are a little more expensive than you might think. They run about $300 a piece. So if you have to do a full panel to rule out things like melanoma, carcinoma, lung, gastrointestinal, it's breast, etc., you're easily going to break $3,000 worth of testing, and you may not ultimately be ahead. You may not actually know what you're dealing with. So we had to say it was metastatic carcinoma of unclear origin. Now you might argue, oh, well, you can do CT scans and figure out where the tumor came from. Maybe that might help, of course, but it's also possible you may not find a tumor anywhere else in the body, which can happen. It's weird, but it can happen. Or you'll find in some of these poor people, you'll find tumor everywhere. And you won't necessarily know where the thing started, because the biggest tumor in a patient is not necessarily where that tumor started. It could be a metastasis that just exploded. Again, just like that prior case, next-gen sequencing showed mutations that were not non-specific, that could have been coming from any kind of cancer. So we had to run through, this was an earlier edition of the classifier that actually landed, compared to all the other probabilities, it identified lung as being far and away the most likely source. Excuse me. And in this case, that aligned quite nicely with the radiology, where she did have this big lower lobe mass with hilar lymph node positivity, specifically because, of course, that CDX2 positivity made us think gastrointestinal. There was absolutely nothing abnormal in the biliary tree, liver, spleen, pancreas, or GI tract, or anything like that. So in this case, we would say, okay, it's a barren CDX2 positivity, but it's still ultimately a lung cancer. And that's, again, where methylation profiling can really help us. All right. Last case, 40-year-old man who had a right frontal tumor that was diagnosed as a high-grade glioma in an outside hospital. And you can see the tumor here. It's all a mishmash of various things. It's a Cousa specimen. And it's got what looks like perovascular or pseudo-rosetting going on here. At least that's the impression. So it may be an ependymoma. Very mitotically active. You can see 5 mitoses just in this high power field alone. So we knew it was an ependymoma. But to further refine the prognosis, we wanted to screen it. And by next-gen infusion screening, we were able to determine it did indeed have a ZFTA fusion, formerly known as REL-A fusion, as well as, once again, our old friend, homozygous deletion of CDKN2A and B. By methylation, just as an orthogonal analysis to really nail down that this was indeed an ependymoma, it mapped to the REL-A or ZFTA subset of ependymomas, which are known to be exceptionally aggressive among supratentorial ventricular tumors. And so in this case, the methylation profiling was an orthogonal layer, so-called the Swiss cheese model. We think about it in terms of Swiss cheese. So for any robust system where you're trying to minimize errors, the best thing you can do is layer one independent analysis on top of each other, because every analysis, no matter what you do, whether it's microscopy or molecular or whatever, radiology, they're all going to have their strengths and they're all going to have their weaknesses. And if you layer on enough orthogonal assays or evaluations, the odds of a mistake slipping through all those different layers of Swiss cheese drops substantially. That's why, for example, cars are a lot more reliable than they used to be. That's why air traffic, even despite the horrible crash in DC, air traffic is way safer than it used to be, because that Swiss cheese model was implemented in auto manufacturing and in aviation. We're now, with this molecular testing, we're doing the very same thing here in patient care. All right, I lied. I think this is the last case. If it's not, we'll finish up with this one. This is a spectacular case. 47-year-old man who had a left temporal lobe tumor that had been diagnosed as a GBM in an outside hospital, and you can see it right there. Now, under the microscope, by the way, ignore these little triangular shapes. That's just an artifact because they put these stupid sponges in with the tissue. Just ignore that stuff. When I got a look at this tissue, I saw what looked like dysplastic neurons that were disordered and hanging around. I didn't see any mitoses or anything like that. But I did see binucleate ganglion cells. So I'm thinking this might be a ganglioglioma. But I found out from the outside hospital that it had been diagnosed as a GBM, which happens. Community practices very often struggle with these kinds of tumors. Again, more dysplastic neurons, further emphasizing to me that this was a lower grade indolent process. There was also neurons in the deeper white matter. The line between dysplasia, cortical dysplasia, and low-grade neoplasms can be kind of fuzzy. Now, when I received the specimen, it was actually 2 years after the original diagnosis. And in the clinical records, 2 years later, they're reporting phenomenal response to radiation and chemotherapy, not a hint of tumor recurrence at the original site. It almost looks like that original tumor was photoshopped out of the first axial, the MRI. Now, if you really understand IDH wild-type GBMs and you see a response that good, the first impression has to be, or the first suspicion has to be, the original diagnosis was mistaken, because IDH wild-type GBMs are going to recur 2 years later, even with good resection, radiation, and temozolomide. So seeing this raised a red flag to me. And it also, I think, raised a red flag to the clinicians, which is why they sent me the case for consultation. On top of it, though, and this was a really funky complication for this poor guy, he was complaining of chest and back pain. And on subsequent radiology, you can see this big mass in his chest wall that's breaking through his ribs. You can see multiple lytic lesions in the vertebral bodies of his spine, including a pathologic fracture down here in the lumbar spine. And so they did a CT needle biopsy of the chest wall mass. And this is the mass. This is literally what it looked like. It's white balanced and everything. So compare that with the original tumor that I showed you earlier. They don't look anything like each other. And yet this chest wall mass was positive for GFAP and OLIG2. So those are both pretty good glial markers. So we got a glial tumor that is in the patient's chest, and presumably in the patient's spine. By next-gen sequencing, we did the original tumor as well as the chest wall mass. And they were exactly the same, except for the chest wall mass had picked up a p53 mutation. But otherwise, they had BRAF and TERT mutations, etc. And SETD2 will alter the epigenome. It's kind of like histone mutations. So we ran the tumors through our, at this point now, it's an 850K methylation profile. And it landed squarely in this little purple cluster towards the center, pleomorphic xanthoastrocytoma, PXA. So we, based on that, were able to revise our diagnosis and say that it started out as a grade 2 PXA, but now it's progressed to grade 3 PXA with metastases to the chest wall and spine. And because we were able to detect that BRAF mutation, they put him on BRAF, or what do you call it, MEK and ERK inhibitors. And as a result, despite all the metastases, it turns out he also had metastases to his liver. He's still alive now, going on 3-4 years later. And this mysterious kind of tumor, which we used to think was super rare, but now that we're doing more and more molecular testing, it's coming up more and more often. It can look a lot like a GBM, or because it can be like a lot of these MAP kinase associated driven tumors, it can be associated with cortical dysplasia that's nearby, which is what we saw. And they can also metastasize to really strange places. They in particular seem to have a predilection to metastasize into bones. They'll metastasize into the skull, they'll metastasize into the vertebral bodies and the chest wall. All that stuff has been described before. And this was a remarkable enough study that we published it a few years ago as a case report. All right, and we're gonna have to, I think we're gonna stop there because we're coming up on time here. The upshot here is that I hope I've impressed upon you that molecular diagnostics are now an indispensable part of neuropathology. You really shouldn't practice one without the other because, again, that Swiss cheese model, they have orthogonal layers of quality assurance, quality control. So I'm pretty much done here. If you like, I tweet out cases like this on occasion when I encounter them. And thank you very much. I'll take any questions.
Thank you, Dr. Horbinski. That was a phenomenal talk, as expected. I'll add to what you finished on. I think the molecular diagnostics, you should not practice neuro-oncology without molecular diagnostics, not just neuropathology. I think it's a integral part of any care for any cancer patients in the CNS that we encounter. A couple quick questions. We have 5 more minutes. Uh, you mentioned the last case was the BRAF V600E, which is a very well-known marker. There's a lot of immune therapy or targeted therapy against it, or checkpoint inhibitor. For all these melanomas, for the lung cancer, for the breast cancer. We've tried a few for our GBM with the IDH and all that stuff. In your opinion, why have we failed to find an immune therapy that actually works for GBM minus the Stoop protocol or the Optune? We haven't done much change in GBM.
Well, there's a couple of reasons for that. One is the immune microenvironment of the brain, especially for GBM or even IDH mutant tumors, seems to be a lot more immunosuppressive than it is for a lot of other cancers elsewhere in the body. So there's that. That's the first thing. So it can be hard to train, and there's good reasons for that, actually, evolutionarily speaking. The brain, it being an enclosed environment, doesn't have a lot of room for swelling, for those sorts of things, and that's going to be fatal. So the brain has to really tamp down inflammation to a much greater extent than the rest of the body has to. And when it comes to tumors, it ends up doing largely the same thing. So there's that. There's the anti-inflammatory aspects of the tumors, and the myeloid-derived suppressor cells and things like that tend to be very immunosuppressive. And they can comprise up to 40% or so of the dry weight of a GBM. I mean, there's a lot of non-neoplastic cells mixed in there, more so than we used to realize just based on histology. The other thing is that a lot of these therapies are not just immunotherapy, but other sorts of targeted therapies, what have you, oncolytic viruses, all those sorts of things, are predominantly targeted towards the original tumor site. We treat what we can see. Even though we know there's tumor that spreads beyond the radiologic boundaries, we still focus on that. We still let tumor board look at that and say, okay, based on radiology, this patient's responding or not. But our data that we're showing now here, we published a few years ago, and then we're working on a follow-up study right now, is that these patients at the end of stage, when we do autopsies on GBM patients, most of the time the tumor at the original site is controlled fairly well. The tumor cells are sick. They're not very proliferative at all. And they're not in good shape. It's the tumor that migrates away, specifically into vital structures like the brainstem, which neuroanatomically is like a big funnel. And wherever the tumor arises in the cerebrum, it can end up in the brainstem. And it can get there pretty quickly. Within months to a year, you can have a lot of tumor in the brainstem. And it looks like that may be accounting for the brainstem symptoms that predominate at the end of life, like hypersomnolence, difficulty chewing and swallowing, those sorts of things. Where in the old days, they used to be attributed to herniation and mass effect of the tumor. And that was true in the old days before temozolomide and better neurosurgical treatment and radiation and all that. In the old days, most patients actually did die of herniation from the mass of the tumor. That is not the case anymore. Now, it looks like very similar symptoms arise from direct tumor extension into things like the brainstem. So if you're coming up with a therapy that does not take that into account and in some fashion does not address the tumor that has migrated away, the therapy is probably going to fail. So if you're like injecting something right at the original tumor site, unless that therapeutic spreads everywhere in the brain, and it probably won't, you're not likely to see any meaningful extension of survival. Related to that, another big irritation I have, with the field is that generally speaking, you're coming up with new therapeutics based on preclinical models of studies and everything. They look great, you know, new therapy, this, that. And then you can't get the therapy into a clinical trial unless you're focusing on patients who have failed frontline radiation and temozolomide. That is the dumbest, because there's a lot of therapeutics that probably would have extended patient survival at least a little bit, but they failed because they were tried first in the recurrent GBM setting, where you've given that tumor even more time to migrate to vital structures like the brainstem. And so you're almost setting that therapeutic up to fail. And then when it does fail, when it fails to meaningfully extend overall survival, oh, we're going to drop it. It failed. It didn't work. And you don't even try it on newly diagnosed tumors. So that is a persistent, pervasive problem in how clinical trials are approved and conducted. I think they really are set up to fail when you're focusing just on so-called recurrent glioma. And I say so-called because how can a glioma technically recur when it never disappeared in the first place? It's not like it magically reappeared. It was always there, even if you couldn't see it radiologically.
Yeah, I agree 100%. That's great perspective. Hopefully we can get it over that hump. But where do you see what's the next frontier in neuropathology? And obviously now we're breaking down even grade 4. The problem is now we have, you know, the true GBM, and then we have the IDH a mutated astrocytoma grade 4. They have different maybe in survival, but they don't have difference in treatment. Like from a clinical, I mean, maybe obviously trials, but in the standard of care, it's pretty much the same. So where do you see the future of neuropathology and how we can address, you know, now that we understand better these different tumors, we can actually say, okay, well, you get treated differently than you.
Yeah, specifically as concerns like IDH mutant inhibitors and everything, I think we're going to have to, because right now it's a little puzzling why the inhibitors only work in lower grade tumors and not in higher grade tumors. It's also a little unnerving because one mechanism of progression to higher grade IDH mutant tumors is to lose the IDH mutation. So treating them with an IDH mutant inhibitor, is that really such a hot idea? You know, I mean, there's some fuzziness about why the therapeutic seems to be working. It's not at all obvious why. I know they say, oh, it induces differentiation, blah, blah, blah. I'm very skeptical of that data because we haven't been able to recapitulate it in our lab. But at any rate, I think one of the biggest things that was specific more broadly with neuropathology is you've seen all the assays I talked about. We've got the methylation array, we've got the sequencing, we've got the copy number, all that business. It turns out a number of groups, including us, are working on one test that replaces all those other tests for a fraction of the cost and gives you, instead of 1% of the methylome, gives you 100% of the methylome. Instead of just 500 hotspots on the next-gen sequencing panel, it gives you the entire whole genome sequencing. You know, those sorts of things. And it's called methylation sequencing, methyl-seq. Now, methyl-seq's been around for a while. It's been the purview of frozen or fresh tissues because you couldn't historically do it on paraffin-embedded tissue sections. Well, now with some technical innovations, you can. So now that you can do it on FFPE tissues, now all of a sudden it becomes plausible on a routine prospective clinical basis, whereas before it just wasn't. The only catch with it is it's so powerful that you have to start from scratch. You have to create your own methylation classifier libraries from scratch because you can't build on a library that only sampled 1% of the methylome to begin with. Mm-hmm. You know, you got to start over. So that's exactly what we're doing as we speak, is trying to get this off the ground. And just to give you some examples of costs. So like for us to do the full workup on a glioma patient or, you know, a suspected glioma patient, it's going to cost over $10,000, which is still a small fraction of total patient care costs, but still 10 grand. We could do this methyl-seq assay, which gives you, like I said, replaces literally everything else we're doing. And we could do it for a few grand. And from technical reasons, you don't need an array chip. You don't need a special plate reader. It's the innovation is all on how the tumor library is prepared. And once the library is prepared, you just throw it into a standard sequencer, which everybody has these days.
Mm.
And you just need special bioinformatics at the back end to make methylation and mutation calls. Once that's established, and we've shown it works, uh, you're off and running. So that's going to be the next really, really big thing. And it's going to, I think, completely upend a lot of the molecular testing and the classification system that we currently have.
Yeah, we're running out of time. I just want to get your opinion on what are your thoughts on obviously everybody, there's a big places that everybody's working on these things. Um, what are your thoughts on actually combining these tumor banks into one big data set, that now instead of having 10,000s of data separated, now you have hundreds of thousands of data that will give you a lot more understanding and insight into these tumors?
Timing, because we just had the discussion with the NCI and NYU, and we're like, in us, we're the three major centers in North America that are doing methylation profiling on a routine prospective basis. And there's going to be a few other players emerging as well. And we're in active talks now to harmonize our banks and share in one common classifier. Heidelberg probably won't be involved because they've already created their own company, Epignostics. And so there's some proprietary issues with their bank, but we're going to recapitulate this and we're going to create a North American consortium where we're doing that very thing.
Perfect. Well, thank you. Thank you so much. We're taking enough of your time. Appreciate you giving us this talk this morning. For everybody, I think the CMEs are in the chat, and I believe that the talk will be posted online. We'll keep you updated. Thank you so much, Dr. Horbinski. This was absolutely fantastic.
Thank you very much. Have a good weekend.
You too.